the ridiculous things doctors tell their patients is unbelievable.
Oh, mine told me women don't need testosterone. So,
Ah,
I mean, this is the doctor in Spain. I'm thinking, wow, okay. I took my jaw off the floor and I left the room and found somebody else.
yeah, because you've done your homework. Now suppose you hadn't.
Yeah.
And suppose you're naive, you don't have enough information, and way too many women and men go to professionals with not enough background to be discerning.
All right. Well, I am so excited to have on for a third time Carol Petersen. Welcome.
Thank you. It's my pleasure. So nice to see you again.
I always have to bite my tongue when I say your name because I want to say Dr. Carol Petersen. I've said it several times because you know more than a doctor sometimes. So if I say it by accident, oh, you're not a doctor, but it's Carol Petersen.
I'll just consider it a term of affection.
Yes.
People do. And,
Oh, I've been called
um,
Dr. Zora, and I'm like, wow, that really sounds good. Maybe I should go get a PhD.
yeah, I'm not a PhD, I'm not a medical doctor, but I would submit I've probably done more research than many people who have those things under their belt.
Mhm.
Because I now have all this time that I've really devoted into hormones, and particularly progesterone, which I feel it's almost a conspiracy against progesterone, that when progesterone is lacking, it opens the door to conventional medicine prescribing so many drugs, crutches and things that further deplete your health when all that was needed was progesterone. Can I tell you a
Mhm.
story? Just yesterday
Yeah.
morning, I had a 15-minute session. Two ladies showed up from the Czech Republic,
Hmm.
and they had watched some of my videos and maybe even the one with you. So the one said she had headaches for 40 years.
Wow.
And I said, "Did you try progesterone?" And she said, "Yes." And I said, "Then what happened?" She goes, "No headache."
No.
And like
Wow.
the three of us are in tears. Imagine 40 years of pain that was unnecessary.
Wow. What kind of progesterone did she take to mitigate the headaches for 40 years?
They're in Europe. Utrogestin's available there. They said
Yeah.
that was the only one available to them.
So was she taking 100 milligrams or did she have to go up?
I didn't ask her what dose she used for relief.
Uh-huh. I would.
I want details, but in the end, it doesn't matter. Everybody's so individual.
Yeah, that's true.
And it's natural. We ask each other, we want to know what worked for you, right? Because I think it might work for me too, which is human and natural, but it might not be quite the story. And that's when people do get discouraged because everybody is unique. We constantly look to have order in our world. That's our reptile brain, I think, wants order. And when you work with progesterone, you don't get order. It's a very volatile hormone and will differ quite a lot with your stressors, with your diet, what you come into this with. If you've had 40 years of low progesterone, it may take you a lot more progesterone to get to an even keel. So
Mhm.
I say, once you've mastered progesterone and you have to monitor yourself and learn to monitor yourself, everything else is easy peasy.
But I'm wondering though, if it's going to be just the progesterone or in balance with estrogen.
Definitely, where you need the progesterone is to actually balance that, but you need it. It's adrenaline's involved, histamine's involved, insulin glucose disorder, all involved. Unfortunately, it's not a little flow chart, if this then that, which again, we like simple and we like order. It's a little more complicated. It involves all the endocrine systems in your body, and it involves your whole lifestyle and everything. And it's sort of like all these things you've been doing all these years and floating along, suddenly as these hormones decline, progesterone first, but other ones too, you're hitting the wall because of insufficient hormones. And that's when they say, oh, eat broccoli. So
Yeah.
if you're menopause and broccoli.
Yeah, well, we should eat your broccoli for sure. If it takes away your hot flashes, wow, amazing. But for most women, it's probably not enough. And we're going to be focusing on progesterone today. And I'd love to take a little bit of a deeper dive and explain what it does and what it's for. But before we do, a lot of us get confused when we hear the words progesterone. We also hear the word progestin. We hear progestogen, and it could be really confusing. So why don't we, and maybe there's more that you know of, why don't we clear up the differences between all of those?
The medical literature is just rife with confusing those terms. And as you pointed out, one of your questions, they may call progesterone a progestin, which is generally saved for the synthetic analogs of progesterone, but not progesterone. Progestogen means it has progesterone-like activity, as in shedding your uterine lining or doing other progesterone-like things. So some people think it's an overwhelming, like over umbrella kind of term, progestogen, including progesterone and the progestins. But you can't count on that definition either, because it falls apart when you start reading some articles. It's really, really important to identify within an article exactly what they're talking about. It really is a challenge. And let me just harken back to an old challenge, which way back, we started having over-the-counter creams with relatively small doses of progesterone in it. And the FDA was taking a rather negative stance to that. So companies producing these products would not say progesterone, they would say extract of wild yam, which it's a whole different thing. You can have an extract of wild yam, but that's not progesterone. They used it as a synonym. So now people think wild yam yields progesterone, and it does not. The kind of confusion all that created is unbelievable, and continues to this day. You still might see it. So on one hand, I admire people's ability to try to confront obstacles and go around, which is serving to do. But the other hand, it introduces a lot of confusion in people's minds. So extract of wild yam could be an extract of wild yam, and it would be an adaptogen. It would have some of the four-ring structures similar to cholesterol, but it's not progesterone. However, the company may be using progesterone and calling it extract of wild yam.
So the way I understand it, whether it's estrogen or progesterone, these can be coming from plants. This is when we say, oh, bioidentical, we call it quote unquote natural, as opposed to as a progestin synthetic. But in fact, the way I understand is that, maybe there are some compounds they extract from the yam or soybean, but yet they have to go through this whole chemical process, and we have to synthesize it to create the hormone. And correct me if I'm wrong. So it's not, if some people think they're actually just eating a yam, some people, well, why don't you just eat yams or soybeans instead of eating the progesterone or estrogen? And maybe you want to explain why it doesn't work like that.
Okay, truly the process should be indicated as semi-synthetic, because you do extract from the plant source a four-ring structure that resembles cholesterol. In fact, you could be extracting cholesterol from animals and doing the same process that had been done. So once you have that four-ring structure, actually was Russell Marker who achieved making progesterone for the first time with a process using yams and then altering the molecule slightly to be identical to progesterone. This was a huge step forward, because now we could use progesterone. Actually, progesterone had been used experimentally a little bit from placenta. They would try to extract progesterone, which would be very rich in placenta, but this was very, very, very expensive, so made it pretty much unavailable. However, it wasn't long after Russell Marker succeeded in the progesterone synthesis, the semi-synthetic process, that drug companies started looking for ways to alter it. And one of the first, I think, was norethindrone, a progestin, which you find in birth control pills pretty frequently. And this does not behave like progesterone does. It has some progesterone activity, but not the whole breadth of what progesterone can do for you. And in fact, it has a negative effect when you put altered chemicals in your body, really of any sort, but with the hormones, it will suppress your own hormone output. So for example, if you are using a birth control pill, there's no sense at all for you going to test your estrogen levels or progesterone levels because they're going to be flatlined. You have stopped your ability to make your own hormones.
Sounds like menopause when you're 25 taking birth control.
Well, you know, it's as far as the natural process is concerned. So those synthetic hormones do have some activity, or if they didn't, they wouldn't be used at all. But it really does interfere with your own endocrinology, and in a big way. And I was appalled to see that now doctors are turning toward using birth control pills for menopausal women. It's gotten to be pretty popular. Susan Diadamus wrote an article in the New York Times, it was in the Weekend magazine, a big thing on menopause, and she's like maybe a Pulitzer Prize winning author, and she and her colleagues are now having trouble doing the work. They're searching for words. They don't lack ambition and stamina and stuff to do the work they were doing. So she went around to NYU, New York University, Columbia, Mount Sinai, these very big teaching hospitals, trying to find a solution to her own perimenopausal symptoms. And, you know, she did all this work, and a couple things were appalling. She settled on birth control pills as her answer. And she made this rather alarming observation that in these teaching institutes, the doctors that were now in training were being taught there's nothing you can do about menopause. So just forget about it. And I found it's really alarming. And then I have to question how good of a reporter is she, because I know 100% that there are lots of doctors in the New York City area where she was scouring do bioidentical hormones and successfully treat all these symptoms. So it's shocking to me.
It is shocking. So let's tell the listeners then, what's the problem with taking birth control for menopause?
You have a hormone deficiency, so we're just going to stack you up with synthetic hormones, and it stops your own already weakened production. It fills the receptors, so you may get some activity, but it blocks so much. One thing I would be really, really concerned about as I was working, I found women were primarily concerned about losing their mind over and over and over again. If you want to lose your mind, use a progestin, because these are water-soluble molecules, cannot make it in your brain. Probably a good thing, but you're not making progesterone because of them. And progesterone is such a brain-active hormone that allows you to think and concentrate. So you're just wiping out your brain. So very, very.
Well, so the answer is if you're concerned about your brain health, you don't want to be on a birth control. And they're much higher dosages as well, birth control, than menopausal hormone therapy. Is that correct?
Well, I don't know how you say that, because they're very seductive in the propaganda around that as well. So way back when birth control pills were first introduced, the strengths or the powerfulness of the particular hormones was much greater than the ones being presented now. But how do you compare apples and oranges? You can't say this many milligrams of, let's say, medroxyprogesterone acetate, because you brought that up. This is a synthetic progestin. So they might tell you to take 2.5 milligrams of medroxyprogesterone acetate every day. What dose of progesterone would be equivalent? And you have to say, in doing what? It's just
Yeah, and what's the objective,
like
right? Because when it comes to menopause therapy or hormone therapy, you have the camp that says, let's just take the symptoms away. And then you have the camp that says, let's take the symptoms away, but we want to protect your future self so that in your 70s, 80s, and 90s, you're in a good condition. To me, it seems like, what is the objective? What do you want? And then they may have different approaches or different dosages and types.
Right. They'll say that 2.5 milligrams of medroxyprogesterone acetate protects your uterine lining. And that's debatable. Women who have done that course still may suffer bleeding and endometrium growth that they have trouble with. This is another thing that's really shocking to me, is heavy bleeding that occurs around menopause, perimenopause. Some women have extraordinarily heavy bleeding. Well, why is this occurring? And it's occurring because there's low progesterone in the first part of the cycle, the follicular part, days 1 to ovulation. That progesterone comes from your adrenal glands. And it should be far more prevalent than estrogen is. And if you put things in the same units, we're also deceived by picograms of estradiol versus nanograms of progesterone. Looks on the same graph, and they shrink the progesterone down 1,000 times. So it looks like you don't have any progesterone. Well, you actually don't from the ovaries, but you have a lot from your adrenal glands. And so if you're under any kind of stress at all and depleting your progesterone, that estrogen stimulation is going to be more and more intense, and you build up a big layer. And then when it comes to bleeding it, you have severe bleeding. I've known women even to need blood transfusions. And sometimes doctors just leave you like that till you beg for a hysterectomy. And indeed, heavy bleeding is the major cause for in the United States. And the number is something from 600,000 to 700,000 hysterectomies done every year. And in the meantime, you could have fixed it with a little bit of progesterone in the follicular phase, not having this huge buildup, not having these huge bleeds, just having normal bleeds. Unbelievable.
Why don't doctors know this? It's such a simple solution. And is it because there's not enough research, they're not trained, or we don't really know it's something new? Why don't they do this? Why don't we, it's so easy.
Yeah, part of it is they're trained not to know.
Yeah.
So, like I said, with the new doctors getting trained that there's nothing they can do. And then another problem is now they've made inserting a Mirena IUD, which contains a progestin. So the promise is that it'll stop this constant bleeding. Sometimes it will, sometimes it won't. But now you've introduced a nasty progesterone suppressing drug again for long periods of time. It's relentless. You have this constant flow of this hormone getting into your body, which is a non-hormone. It's a drug, and it's blocking many of your endocrine functions. So that's a horrible situation. I've had women contact me, say, oh, I'm using the Mirena for birth control. Can I use progesterone to solve all these symptoms? Like, I have emotional symptoms, I can't sleep, I have headaches while I'm on the Mirena. Would extra progesterone help me? I go, no, take the Mirena out, because you're blocking your body's access with the foreign hormone. It's just not going to work.
So if she doesn't want to become pregnant, let's say she wanted a birth control, thought, oh, I'm going through perimenopause, but I don't want to get pregnant. This kind of takes care of both things, but not everything, like the sleep and et cetera. So what would you say to the woman who still wants to protect herself from getting pregnant?
You have to use something non-toxic like barrier methods.
Like what? Barrier methods. Oh,
Yeah, yeah,
okay. Like a condom.
yeah, condoms and diaphragms.
Mm-hmm.
Actually, diaphragms were very good birth control. Part of the reason that their statistics would fall a bit was they included those people who left the diaphragm in their drawer and didn't use it. So
Yeah, when you read a study and you're trying to figure out, they're saying the words progestin and progesterone, they're throwing it out without any understanding of what the difference is. How do you tease out in the research what it really is?
usually you can tell in the details. And in fact, you have to go usually beyond the title, which is often deceiving. You've got to go beyond the opening discussion. You've got to go into the whole article and see exactly what they used and how they used it.
Mm-hmm.
There's other little tricky things, like sometimes progesterone use has been condemned. Like there was a study, and it's an often cited study, with using progesterone. I believe it was oral capsules, 100 milligrams twice a day in the luteal phase for 10 or 14 days. I forget what the duration was. It said had no good result for PMS symptoms. At the same time, I'm working in pharmacy. We start with a minimum of 400 milligrams and go up from there according to the clinical picture, and are having real success with women. So in the medical literature, then you get this mantra, progesterone is no good for PMS, because of this poorly designed study.
Mm-hmm.
This happens all the time. Just
Yeah, so we have to go inside. So that kind of brings me to the next question, because you may find that in the study, they maybe will quote, we used Prometrium. That's the brand name, right, for progesterone. This is the oral bioidentical progesterone. And then if you dig in a Google search or trying to figure out what this is, and for example, there's a brand out there called Aurobindo, and it's called progesterone, bioidentical progesterone, but then they would use the word progestin on the label. So then you go, is this progesterone, or is it, or is it, I don't want to say synthetic, half synthetic like progesterone, or a highly synthetic one like progestin? How do you know?
exactly. So that's actually sort of mislabeled to introduce that progestin word. If it's not actually, if it is actually progesterone and you call it progestin, for the most part, we do think of a molecule that's altered away from progesterone. Hopefully somewhat progesterone-like, but maybe more testosterone-like. Some of these molecules have features of testosterone.
I don't understand the answer. So if it says progestin on it, when we know it's a bioidentical
Yeah, it's
progesterone,
misleading, totally misleading.
yeah, it's terrible, because this actually happened to a friend of mine who's panicking and says, you told me this was a bioidentical. My doctor told me it was bioidentical. I go to the pharmacist and he says he doesn't know the difference between bioidentical and progestin. He didn't know all this stuff. And then I dug into some of the research and I confirmed it's fine. I know it's confusing, but here we are, even me going, what's going on? I have to dig in a little deeper to find this out. And if the pharmacist doesn't know this,
This is appalling. I would ask if he failed his biochemistry.
yeah, honestly.
Seriously. And the same position has been like the North American Menopausal Society, the Endocrine Society, the American Association of Obstetrics and Gynecology. They write stupid stuff like all estrogens are the same.
Oh my goodness.
And
Wow.
this is by committee, and those committees are influenced very heavily by pharma to write these ridiculous things. So you actually have many, many doctors in lockstep with these organizations, because if they're not, somehow they could be cited by their regulatory agencies as not being true to standard of practice.
Yeah.
So very, very insidious.
And in case anybody's listening now and still doesn't know, why we're laughing when we're saying they're all the same. Well, for example, the synthetic estradiol, for example, it is oral estrogen. Let's say you're taking that, it increases your risk for blood clots and strokes. And if you take the transdermal estrogen or estradiol, then you are much safer and it doesn't have that elevated risk. So when a doctor or you read something and it says, oh, hormones or estrogen can cause blood clots and stroke, that's why you say, wait a second. It's partly true, but it's also not true. And so we have to see the differences. So to put them all in the same basket is an injustice to estrogen.
Yes, and you touched on something that I found that is actually a problem, because you just said estrogen generically, oral estrogen, including estradiol, which would also include Premarin conjugated estrogens. The studies, most of those studies that point to the problems with oral estrogen were Premarin versus estradiol. It's a rare time you can find estradiol against estradiol. And I was at a conference and this naturopath was speaking, and she was doing the same thing. Just like for progestins, for progesterone, just saying estrogens, you've got to be specific because there's different qualities. So I found estradiol, Estrace or generics, has been on the market almost as long as Premarin. Does it have those same side effect profile? It does not.
Oh, it
And
doesn't. I didn't know that.
no,
Interesting.
no. And I tried to do a pretty big dive in here, and of course it's all messed up. And even the non-conventional doctors who should be clued in on this kind of error really start going, oh, we're not using oral estrogen, because oral estrogen really was Premarin. A study comparing Premarin versus estradiol should never be published. It's apples and oranges. So why did these things get extensively published? Well, there's probably a big push toward the topical estrogen patches and the gels that serve as a alternative to Premarin in the marketplace. So perhaps there was a little bit of a push there to paint Premarin as the bad guy. I saw a really interesting study, and it was from the people that made the product Ogen. Ogen was estrone. Okay, so we demonize estrone, but estrone is our major estrogen after menopause, coming from our adrenal glands, coming from DHEA. It's a normal and natural hormone for us. But this company did this study using Premarin, one dose of Premarin, and they went out like many months measuring equilin sulfate and equilenin sulfate. These are estrogens that are unique to horses, don't appear in humans, and it was still circling around in your body. And I thought, what drama here? What happens when you take this daily for decades? You're having such a buildup in these non-human estrogen things. It's a problem.
Yeah.
Yeah, we're still using Premarin.
I find that amazing, right? I heard through the grapevine, I don't know if it's true, that Evan Blooming, who wrote the book Estrogen Matters, actually prescribes oral estrogen. Now, I don't know if it's the Premarin or the other one.
He prescribes Prempro.
But why?
Actually, Dr. David Rosensweet, who you know too, he went out of his way to fly over to where he was to meet with him and said, why don't you stick with bioidentical hormones? Wouldn't this be even more impactful? As Avril Blooming's point is, even with Prempro, women post breast cancer treatment have a better quality of life and no particular increased risk of a recurrence of breast cancer while using Prempro. He was so that's his position. And he's got to be paid by by somebody. But what's kind of interesting, he's deep in the conventional medicine world. As you can tell when you read the book, I really hated the book. But he has a point, and I had seen studies earlier that even with using Premron and maybe Prempro too, you didn't have a recurrence of breast cancer particularly, yet we tend to put women on estrogen blockers and starve those poor women of hormones, which is really, really bad, probably shortening their lives, not from the cancer, but from withholding hormones.
Mm-hmm. Amazing. Yeah. So, all right, let's move on, because we could get lost in the estrogen conversation, which maybe we have to follow for another time, because I still have questions. Then when you mentioned, so I had one of my questions is medroxyprogesterone. If somebody sees this on the label, what is it?
It's a synthetic progestin, not progesterone like. It's primarily marketed to protect the endometrium. Like, it will help you bleed. And way back when I was much younger, to illustrate some of the problems with this drug, they would give women who suspected they might be pregnant, they would give them 10 days worth of medroxyprogesterone acetate, 10 milligrams. So if you didn't bleed after that, you were probably pregnant.
Mm.
And that was actually pretty common, surprisingly common. And
It was like a form of pregnancy test.
Yes.
Uh-huh.
But then they discovered they were producing quite a lot of birth defects with this little sample test.
And we're still prescribing this too.
Yeah, we're still prescribing this. We're prescribing it to menopausal women, so it's okay.
It should be called medroxyprogestin then, because the word progesterone in there is misleading. Terrible. Okay. Well, good we're here talking about this to clear some of this confusion. And you mentioned, the main reason why many doctors prescribe progesterone is to thin out the lining of the uterus, because we don't want it to be thickened to have this breeding ground for uterine cancer. So let's talk about the other things that progesterone does, because women who have had hysterectomies are often denied progesterone because they say, you got no uterus, so you don't need progesterone. What do you say to that?
That's another one of those committee decisions by people who didn't pass their biochemistry and physiology courses and are paid by drug companies. That's where all that comes from. Really, really and truly. But I'm contemplating writing something about progesterone, saying how much progesterone does your body make? And John Lee promulgated the idea that was only 20 milligrams made by your ovaries during the luteal phase. I looked all over, and finally I emailed Ray Peat, Dr. Ray Peat, who was the original researcher that John Lee based his ideas on. He goes, "Oh, well, John was in the habit of making things up once in a while." So John Lee was such a prolific speaker. It became like a mantra. You don't need more than 20 milligrams of progesterone. Yet Dr. Peat sent me a study, and it was showing that from the venous return from the ovaries, you could get 100 milligrams of progesterone. That's a big difference.
Yeah.
And then we have progesterone all over your body. Your brain independently makes progesterone out of cholesterol. The Schwann cells in all your nervous system tissue makes pregnenolone, progesterone, and uses it right there. You're never going to see that in saliva, blood, or urine. It's used up. Mast cells, all the mast cells have the whole hormone cascade in there. And when you're off balance with estrogen, progesterone, histamine release is promoted. And then there's this whole series of studies that was done at McGill University about intrachronology, inside the cell chronology. All this progesterone is being made not by our typical notion that you have a hormone producing gland and that's all you get. We're having progesterone being made all over your body, and I don't think we can measure it. I don't think there's any way, but we do have a lot of research done on what progesterone can do and does, and clinically you can follow it, which is really the best. If you're not responding clinically, something's wrong, dose related or other interfering factors.
Mm-hmm.
I had a woman yesterday she's been complaining of low thyroid, and her tests to me, which I look at much more critically, looks like she's tending to low thyroid, but she's in the normal range and she's being put off. Yet her hair is falling out in gobs. She's pale. She's got low body temperature, so her whole metabolic 97s, whole metabolic rate is compromised. She's like classic hypothyroid. And 50 years ago, if you went to the doctor would look at you and assess these things and say you're hypothyroid. Now we have a panel of tests that misses a lot of hypothyroid people. It's pretty shocking. And the doctor's ability to assess their patients is really, really diminished. One of the things I know, and they used to teach, is when you have a physician and patient relationship, as soon as you encounter somebody who's been trained in medicine and who's had, on top of that, if they've been around for a long time, their subconscious is already busy at work before the first word is spoken, doing this evaluation of what is being presented. Like, how does the skin look? How does the hair look? How do they walk? All these things have made an impression. And somebody who's truly a good physician, teacher, healthcare assistant is taking all this in independently of any questionnaire or what you have to say. It's already happening. And we've kind of dismissed that. We have people go to see a doctor, the doctor sits by the computer, doesn't even look at the patient. Asks a few questions, puts a few entries, thinks about a drug he could use, and that's it. It's appalling. Our healthcare system does not return you to health.
Yeah, it's the sick care system. That's how we heard it all the time. Let's then highlight some of the benefits of progesterone. We talked about, well, it protects the uterine lining, but it also, you mentioned the brain. It's great for your brain. There's progesterone receptors there. We know it as the great calmer, relaxing hormone. It can make us feel calm, relaxed, at ease. What else can progesterone do for somebody with their sleep, for example?
Oh yeah, sleep is a very good indicator. Progesterone really has two ways to help you sleep. One is that it shuts down the noise from adrenaline, balances adrenaline, relaxes you, not to make you sleep, but to stop the busyness in your head so you can relax and sleep. The other thing progesterone can convert to allopregnenolone, one of its metabolites, and women produce different amounts of this. Seems to be the most prevalent with oral progesterone over the other dosage forms. And this can produce dizziness and sedation, so kind of knock you out. In fact, some women complain that they're knocked out at night with their progesterone dose and it's still lingering in the morning. They're feeling dizzy and groggy. So for that, I would recommend a couple things. One is, if you're piling up like all your progesterone dose at bedtime, to spread it out. It's better to dose progesterone throughout the day than just put it all at bedtime. So the doses are smaller and you don't have the larger amount of progesterone to make larger amounts of allopregnenolone. Alternatively, you can go to other dosage forms like vaginal, rectal, on the skin. Sublingual dosage forms tend to form less allopregnenolone, but in some cases it still does.
Mhm. What about the woman? I've met some women who are pretty sensitive to progesterone. I mean, even taking this 50 milligram oral or just a little cream, they seem to have the effects of progesterone overdose, which would be just more anxious actually, or some of them are depressed. Some have they just have no zest. They're kind of dragging along, and that is not a good sign. So what's going on with the sensitive type?
That's not an overdose, that's an underdose for the most part. Although with depression, I'd also look for enough estrogen, enough thyroid going on, if that's coming. If one Facebook page calls this estrogen kickback, you take a little bit of progesterone and your breasts hurt and you have headache and you're super anxious, your heart starts to palpate. They call it estrogen kickback. And what you need to do, and this is what I learned with dealing with severe PMS women way back when, Dr. Katarina Dalton started with doses like 400, 600 milligrams. It can be multiple times per day. And we were using instead of the vaginal suppositories like she was using, we were compounding the capsules in oil. So starting dose was 400 milligrams, and up from there in different dosage forms and whatnot. And then we would find women are doing sort of okay and something happens and they start getting estrogenic symptoms again. And the doctors would prescribe like a lozenge, which would quickly bring their progesterone back up. So women need to use progesterone to the point that they've reached calmness. Now, where is that? Now, I've had a couple very, very difficult patients, like they go up, maybe they're around 1600 milligrams or something, seems kind of high. And they're still so anxious with the progesterone. Well, they've set a lot of things in motion, but they probably have had a long history of not enough progesterone, and this just isn't getting to it. One of my most labile clients finally settled on 2800 milligrams a day to keep her somewhat sane. And now she even has some breakthrough when that's not quite enough.
When does a woman know if it's enough? Like, imagine she keeps upping the dose. She goes from 100 milligrams to 200 to 400, 800. And if she's feeling worse and worse as she goes up, you're mentioned there's a breakthrough. When is it time to say, you know what, maybe it's not the progesterone, it's something else. We can only go so high, or 2800, and you're still feeling horrible. What does somebody do then?
Generally, when you get up to 2800, you're already feeling the effects. You're feeling some improvement, but it's scary. It's scary for women who have a big need. And I also look at these women as, how can we help this? One of the big things that you're trying to balance is adrenaline for a lot of women, and there's insulin resistance involved. So how you eat makes a big difference. Dr. Katarina Dalton had her PMS patients eat 5 times a day with starchy foods to try to keep the blood glucose even. So you weren't getting a glucose drop and an adrenaline surge. Way back in the 1950s, she already recognized that. So then we have women and men can't methylate as well as they should. So adrenaline, estrogens, histamine, this is important detox pathways for all of those, which can cause a lot of discomfort. If you're not methylating well, it's a problem. You can tell in a blood test with homocysteine, if it's high, you're not methylating. If you're doing a urine test and you get high 4-hydroxyestrone, that means you're stuck there and you didn't methylate to 4-methylestrone, which is considered much less inflammatory. And then people are doing genetic testing and finding all kinds of SNPs involving methylation where they have some bit of compromised things. So I've been recommending some high dose B complex methyl Bs and betaine hydrochloride and phosphatidylcholine. And now I was listening to a medical conference, And somebody said creatine. And I go, so how does that get involved? And so this is my latest tool that I just found. So creatine is to make creatine in your body, it requires methyl groups, and your body will prioritize the creatine formation over your detoxification pathways if it's needed. So if you're low in creatine, you're losing your methyl groups to making more creatine, and you're not able to detoxify. So the answer is to use some creatine, or natural sources of creatine are animal meats and fats. You need to eat animal products to get that. So it's almost, if you're a vegetarian or a vegan, 100% you should be putting in creatine, because you're not going to be able to have a natural supply in your food. You're just missing out. So you may be compromising all your methylation detoxification pathways for whatever else it takes.
So can we measure our creatine through blood, see if we're low? And if you're not low, do we not, if we're not low, can we assume that our 4 and 16 hydroxy pathways are being methylated?
So the creatinine, we already measure creatinine as a measure of kidney function.
Mm-hmm.
And here's where some discrepancy lies, because people are saying, if you use too much creatine, you're damaging your kidneys because creatinine goes up. The opposing force says your creatinine has gone up because you're taking creatine. Normally and naturally. It's not damaging your liver. I mean, your kidneys. That's not right. So you could monitor where your creatinine is. If it's, I would say if it's normal, and maybe if it's a tiny bit elevated, if you are using creatine, it should be okay.
Yeah, the reason I ask is because it's an interesting hack actually for these pathways. The only thing is I always like to test before I take any supplements to say, you know what if I'm making my own and I'm good? And you can still test other measures to see if you're going down the right pathways, but would it make sense to just test before you start taking the creatine?
I don't know if there's a test for it.
Okay, you can't look at creatinine and just see if that's low, then your creatine is probably low.
I would say if it's high, because your kidney's supposed to be recycling. They say you're having kidney damage for a higher, you're spilling a lot more creatinine, and therefore a kidney's not recycling properly.
Mm-hmm. I don't know if you remember in our live Q&A with our membership group, I mentioned to you that my hack, what was recommended by another doctor a while back for controlling my homocysteine, was creatine. And I tested it, and I've done it, maybe tested 3 or 4 times, maybe 3 times more or less, off and then on and then off and then on. And I see that, yeah, when I'm taking the creatine, my homocysteine levels are better. And
Yes.
that was crazy.
Yeah. So it's another hack for, if you do come up with high homocysteine, you know that is sucking up your methyl groups, and if you replenish that, doesn't need the methyl groups anymore. So now you can work on your homocysteine and your detox pathways. Yeah.
Yeah, we should do a whole podcast episode on creatine and the benefits. And it's been used by the bodybuilder community for a long time for their muscles. And now, everybody's talking about the benefits of the brain, and maybe we should take it all the time, not when we train. And it's just like a big Pandora's box. But yeah, we should do an episode on that. But let's move on, because I'm going to wrap this up. We covered a bit to reiterate a little bit, if the woman is taking her progesterone and she's like, you know what, I'm going to keep increasing. Maybe I need to just get past this block and then get over it. What you were saying is, yes, you can, keep increasing. You'll probably feel a lot better as you go. But if you don't, you got to take a look at other things in your life, your diet, your lifestyle, other blood tests and other markers. Is it your thyroid? Is there other issues? It's not just the progesterone. Did I understand that correctly?
Progesterone can handle so many things, or make so many things much better. when it's in adequate amounts, that it's nice to be sure that you're generous with that. But I always think about, why don't we use some pregnenolone? It's a precursor to progesterone. Why don't we also use hydrocortisone? We can get that over the counter, perfectly good dosing with safe use of cortisol. Dr. Jeffries, he did 5 to 10 milligrams every 6 hours for a low cortisol situation. I've actually had a handful of clients who did better adding that hydrocortisone to their progesterone. Because what's happening, you're depending on your progesterone to try to make more hydrocortisone and cortisone and all the metabolites, which I consider as kind of a reservoir for that anti-inflammatory kind of activity that cortisol and derivatives give you. Now, if this is shot, we sort of call that adrenal fatigue, but it's actually also high adrenaline that's exhausting your store of these corticosteroids. That's what they're called in general. Progesterone's got a lot of work to do, maybe too much, that we have to rely on higher and higher doses. So I'm looking at diet changes. I'm looking at methylation. I'm looking at helping further with pregnenolone and hydrocortisone. I'm looking at maybe a little bit of GABA, because part of the activity of progesterone is at the GABA receptor. A little bit of GABA helps that along. So it can be not needing progesterone to do everything that your body needs. There's other assists, and I think that may be the answer, that you put a whole program together depending on the person to address those particular needs.
Mm-hmm. One thing I should mention, I think it was really useful when I did the menopause method program with Dr. David Rosenstreet, the Institute of Bioidentical Medicine. He mentioned, if you're having a bad week, or it was a training program for doctors, so I was just listening in, he said, your patients, if they're having a really troubled week, let's say, or a couple of weeks that are really difficult, you can recommend them to increase their progesterone dosages for that week, or however time they need to handle it, just to be able to handle things better, to have more resilience, to feel more calm and in control.
Yep, absolutely.
So great.
So he has to have adjustments in his thinking with his urinary hormone thing. You have to allow for deviation with progesterone, but he's on board with that a lot.
He quoted you a lot. He loves you. I mean, like I said, you're not a doctor, but the doctors are looking at you for your research and what you're doing.
Yeah, so, and I'm not, I'm not an original. Katarina Dalton was an original, and her thought, but I also, have been following so many people for so many years, and then you start to see what works and what's not working. Kind of like what you're doing, Zora, with people who follow you. You learn by doing and observing. And what I really love about this whole process, I think it's giving us back our power for us taking care of ourselves. And we need to have that knowledge base and the motivation to do that. And we've been giving that away. We're trained to give it away. Doctors know everything. You have to listen to them. And I can't begin to tell you, and I'm sure you hear it too, the ridiculous things doctors tell their patients is unbelievable.
Mine told me women don't need testosterone. I mean, this is the doctor in Spain. I'm thinking, wow, okay. I took my jaw off the floor and I left the room and found somebody else. But yeah, it's a ridiculous thing. I was shocked to hear that.
Yeah, because you've done your homework. Now, suppose you hadn't. Yeah. And suppose you're naive, you don't have enough information, and way too many women and men go to professionals with not enough background to be discerning. And I experience that if I talk to an IT guy and he uses his special language, tells me this and that. I don't even know what question to ask, because I don't know what your message is.
But the IT, your computer and your Wi-Fi are different than your body.
Yes,
You're living in this body and you want to feel good. And I think
right.
that's more important than my opinion. That's just me. It's only one temple you get to live in. We might as well take care of it.
Yep. And I love the notion of biohacking
Yeah.
because you absolutely, if you're paying attention, you find out what's working for you and what's not working for you. I said, that's what Dr. Phil says. How's that working for you?
Oh, I've used that so much. And and again, sometimes people say it's working great. Well, you know what? I don't care if the research says or doesn't say, you feel great. Go on, it's working.
Yes.
And if it's not, because you listen to all this research or all the books and it's not working for you, well, then who cares? Like, it doesn't matter whatever it works for everybody else. But you're the only one that matters. So
Yeah.
do what works for you. And that's why I do love biohacking too. It's the self-experimentation, trying to understand your own body and how it works. And it changes, right? When we think we got it right, our hormones change or our life changes, and then we got to readjust. But that's life, isn't it?
But having a knowledge base and being the observer, teaching ourselves to be the observer is so important.
Mm-hmm. Exactly. All right. I'm going to let you go. Oh my God. I see I have probably about 15 more questions on my list. I feel like we need to continue the progesterone.
I thought one of those questions was an hour long anyway.
Yeah,
Which one was when I looked at it.
Let's do a part two, progesterone part two. This is progesterone part one. It's wonderful. And I'm so grateful that you're here. I've had you on 3 times and you're my go-to when I have my progesterone questions, and everyone can find you on your website, thewellnessbydesignproject.com. You're on YouTube and you've got Facebook. I'll have your email and all these links in the show notes. And before I let you go, do you have any last words for women going through the menopause transition or something we didn't cover yet you'd like to share?
Eating broccoli is not the answer.
That is so
And
funny.
stopping smoking when you never smoked, and
Yeah.
get a good night's sleep when you can't sleep. This is some of the platitudes that we're handed, and they're empty. They're empty promises. So you have to pay attention to yourself, to your body, and become informed. That's the bottom line. You have to make decisions for yourself, and you have to have good information to do it with.
Exactly. That's why you're listening to the Hack My Age podcast.
Yes.
And there are many more out there too. So thank you so much, Carol. We will see
My pleasure.
for progesterone part 2.
Okay.